we'd already identified that really splits into two different styles of transfusion, one of which I'm going to describe as a chronic low flow situation, which is the TAPS, twin anemia polycythemia syndrome situation. And then what I'm going to focus on more is what we call TOPS, or twin oligo polyhydramnios syndrome. So we've already covered the basics about the fact that the most important thing that we can do in early pregnancy is differentiate between the monochorionic and the dichorionic placenta, and that we recognize that we're going to see a monochorionic placenta in about 30% of cases, and that these are the ones that have the risks of the monochorionic complications. And if you look at twins in general, twins make up about 1.5% of our population. They make up about 20% of our neonatal admissions, nursery admissions. So the question is, why do you have so many twins in the nursery? And as well as the traditional adverse pregnancy complications, preeclampsia, fetal growth restriction, preterm delivery, we have then an overlay with the monochorionic twins. So if you actually look at the epidemiology of twinning, and there's not that many studies that do this, and separate the dichorionics to the monochorionics, then you can see that you have significantly higher risks in the monochorionics than you do in the dichorionics. And you can see actually the dichorionics are pretty similar to singletons in many aspects. So there's four outcomes to focus on. In the monochorionic twins compared to the dichorionics, you're 6 times more likely to have miscarriage, and then you have double rates of perinatal death, fetal growth restriction, and preterm delivery. The other thing to recognize is that there is a temporal timeline to when particularly death occurs. And so for the complications of twin-twin transfusion particularly, it's between 14 weeks and 24 weeks is the main time when you will get acute onset of twin-twin transfusion syndrome that results in the TOPS phenotype, where you have oligohydramnios, polyhydramnios. And this is just a reminder that the 12-week scan is key, and at the 12-week scan we're able to clearly identify chorionicity. This gets harder later in pregnancy, so this really is, I think, a key scan, first to demonstrate you have a multiple, and secondly to demonstrate chorionicity, which is then going to impact the level of surveillance that you have ongoing. So in the monochorionics, you're going to be scanning them every 2 weeks from 16 weeks gestation. So how common are all of these different pathologies? You saw a summary of this in an earlier talk, in Long's talk, but here in our own group, which is listed the penultimate line in this table, we have about a 15% rate of twin-twin transfusion syndrome in these pregnancies. The other thing I wanted to point out to you is that we have a 10% rate where we, despite having surveillance every 2 weeks, have scanned women and found that one or the other baby has died at the time of the scan, despite apparently progress up to that point. So what's the mechanism of twin-twin transfusion? Well, the main feature of twin-twin transfusion is that there's an imbalance in the circulation between the two twins. So as a consequence, the smaller twin is getting less flow through its circulation, less nutrient, and is typically smaller, and because it has less flow in the circulation, will also get oligohydramnios, which is because there's less renal filtration. From the other perspective, the bigger twin has got more flow. Often that twin's a completely normal size, will often have evidence of strain related to being hypervolemic, so things like poor cardiac function, and we'll also be trying to offload fluid through the renal system, so therefore you get polyhydramnios. Now, I think this last hour and a half of talks has made it look very easy to manage twins. It's clear that we should define chronicity. It's clear what we should look for in the context of defining abnormalities. But that is not real world. So real world in Australia is that the family doctor refers patients to ultrasound for a scan at 12 weeks. And the focus of the scan is aneuploidy. On the scan report, the radiologist writes, this is a twin pregnancy, so it's the first time we've identified twins, and then writes what the chronicity is. The report goes to the referring doctor, the family doctor. So the family doctor gets a report at 13 weeks of pregnancy that says this is a twin pregnancy, it's got dichronicity or monochronicity, but the family doctor doesn't recognize the significance of that. So the family doctor then refers the patient into the hospital system for maternity care separate to the imaging. And when they make that referral, they just write this is a twin pregnancy, and they don't write the chronicity down. And then what happens is the midwife, who doesn't manage twin-twin transfusion, reads the referral form and goes, this is a twin pregnancy, I'll book her into the antenatal clinic at 20 weeks gestation. So the first problem that we have in Australia is making sure that multiple disciplines are actually educated about the risks of monochronicity, because we find lots of cases fall through the cracks because people are not considering these diagnoses. And in the context of their total practice, this is a relatively rare event. So this is just an example of a cohort of women that were referred to me in Queensland when I was working in Queensland. So that's now about 15 years ago. The indication for the referral is on the left-hand side. So you can see, for example, a common indication was monochorionic monoamniotic twins, whereas in fact there was severe twin-twin transfusion and the membrane was wrapped closely around the fetus that they couldn't see the membrane. But there was a misdiagnosis there, and the urgency of the situation was missed. Similarly, if I go down the list, 13 women referred with spontaneous onset of preterm labour, but in fact what they had was twin-twin transfusion syndrome, massive polyhydramnios, causing the woman to go into labour. And all in all, about 50% of the apparent diagnoses at the time of referral of these twins were wrong. So this is the classic twin-twin transfusion situation of TOPS. You can see the big pool of amniotic fluid, and then in the middle of the screen we have the fetal abdomen, and actually that fetus is in the other sac. Gravity would dictate that if there was no membrane around that fetus would drop to the bottom of the screen. But here you can see that fetus held against the placenta by a membrane, and if you look very carefully around the edge of the fetus where it comes to the placenta, you can see a little part of the membrane. But this is the classic feature of anhydramnios in twin-twin transfusion. We'll talk a little bit about the classification in a moment, but one of the things that you need to do for assessment is you need to assess a variety of hemodynamic factors. This is an example of fairly severe reversal of the A wave of the ductus venosus, and this is occurring in the recipient fetus, the one that is fluid overloaded. That's why it's in cardiac failure. You can see another feature of cardiac failure, if you look at the image, is that this fetus has high drugs. This is another example of cardiac insufficiency. And here, again, when you're looking at the heart, often it's really important just to put some colour on to be able to see not just inflow into the ventricles, but also to look for regurgitant flow. Sometimes it's quite discreet, so if you just use pulse wave Doppler, you might miss it, you might not be in the right place. So putting a bit of colour on helps you identify the fetus that has tricuspid regurgitation. And this is an example of a fetus that's further down the track. And here what's happened is there is very poor flow and regurgitant flow in the right-hand side of the heart. And this baby's now developing really hypertrophic and hypodynamic right ventricle. And these babies typically also, if they get to birth in this situation, will have pulmonary stenosis as their primary diagnosis. And sometimes you can see more subtle features when you look at the placenta. So you've got a single placenta mass, but you can see a slightly different echogenicity in the two portions of the placenta. And sometimes if you're preparing to treat twin-twin transfusion, you can map out where you think the equator is between the two parts of the placenta, which is going to be a value for you when you're doing the procedure. So you can do that before the procedure by looking at the placental mass. There are other techniques and technologies for assessment. This is use of MRI, which is probably a bit overkill for demonstration of polyhydramnios, but it does quite nicely show you the recipient baby with polyhydramnios, a large bladder. But you can see here the reason we did the MRI scan was actually because of ventricular megaly in the donor twin on the other side. And actually what we were contemplating is whether we should be doing a procedure to try and salvage both babies, which is a laser, or whether we should be doing a selective procedure to salvage one baby, which would have been to do a selective reduction. The other interesting feature here, though, is when we looked at the brain of one twin and came to look at the brain of the second twin, you can see there's actually significant hemorrhage in the posterior fossa and the posterior part of the cerebral cortex. So in fact, the recipient had also had a brain injury in this particular case. So I would advocate that there is potentially a place for doing an MRI both pre-procedure and post-procedure in order to look at brain development in these babies. This becomes extremely costly because you could actually advocate to do an antenatal, a pre-procedure MRI, one immediately post-procedure, and then because you want to look at diffusion-weighted imaging, and then one at about 4 to 6 weeks post, because you want to look at long-term parenchymal impact of the procedure. So that's 3 MRIs, which is obviously very expensive. And we don't have the money to do it. So this is the staging system that's typically used for twin-twin transfusion. It's called the Quintero staging system. Ruben Quintero is an obstetrician gynecologist who works in Florida and comes from Venezuela, so he does some work in Central America as well. He described these 5 different stages of twin-twin, and you can see stage 1 is the mildest, and stage 5 is the most severe. The problem with this screening system is twofold. The first is this is based on grayscale Doppler and did not include originally any Doppler findings, but they have been added at stage 3 at this point in time. The second is that having a staged process like this suggests that the disease will progress from stage 1 to stage 2 to stage 3 to stage 4 to stage 5. That is not necessarily the case. You can definitely jump stages. So, for example, when you advocate not treating stage 1 disease, because there might be a 10 to 15% chance of disease regression and you not needing any intervention, at the same time in your counselling, you need to tell the patient that there is a chance that you will scan them again in a couple of weeks' time, and stage 1 could have become stage 5, that you might have one dead baby with no obvious intervening progress. So what treatment options do we have? When I started doing maternal fetal medicine, we had 2 treatment options. One was expectant management, and the other was amniocentesis. So the treatment option of expectant management, we identified that your chance of taking a live baby home was about 5 to 10%. We then started doing amnio drainage. I was very familiar with this process because this was a job for the fellow, because you had to stand there for an hour with a 50ml syringe pulling out lots of fluid, and sometimes we would do this 2 or 3 times a week. We'd be removing sometimes 2 litres of fluid from around the recipient, and within 2 or 3 days it would have recurred. And typically, if we had done 5 or 6 procedures, so let's say 3 or 4 weeks after we started, we would still be at a point where the woman would labour or deliver. So we were not treating the underlying cause of the problem, we were treating a symptom, polyhydramnios, and we were not really preventing preterm delivery. If anything, we were preventing pre-viable delivery and converting it into peri-viable delivery with significant risks associated with that. So when we were using amnio drainage as a primary treatment process, a nice simple procedure that we could all do, 25% of our surviving twins had cerebral palsy. So in fact, at one point, we decided we should stop offering any therapy, and we had expectant management or termination of pregnancy. Another option, which I think is a significant value and deserves discussion, particularly in places like Vietnam, because of the resource that you need to do this, is the option of selective reduction. Selective reduction is a cheap procedure. You can do this under ultrasound control. You put a relatively large port, about 3 millimeters, into the uterus, in the sac of the recipient, and then you can take the trocar out, and then you can use ultrasound to direct you to the cord, and you can clamp the cord with bipolar diaphragm. So the cost of the procedure is basically the cost of a bipolar diaphragm instrument. So it's a nice cheap procedure. It's relatively easy to do. The only problem is you can only have one survivor at the end of that process. So laser developed in the late 1990s, and there were 2 styles of doing laser. The person that first described this was a guy called Julian D'Elia, who worked in Chicago. He used a 10 millimeter laparoscope into the uterus. That's a big instrument put into the uterus. To do that, he did a major laparotomy on the woman with a big midline incision. If it was an anterior placenta, he would swing the whole uterus forwards so he could put the scope in posteriorly. And to put a 10 millimeter scope into the uterus, he would put a big purse string suture around the site where he was going to put the scope in. So lots and lots of maternal morbidity. I think that the technique really took off when it became an endoscopic procedure, where it was done through the mother's abdomen, so instead of making a maternal incision, and using a much smaller instrument, using pediatric cystoscopes, which are about 2 millimeters in diameter. When you introduce this instrument to the maternal abdomen, you can see the little diagram up at the top right-hand side, top left-hand side. You can see that it gives you a view of the placenta, and that looks like these images here. So the image on the left, you can see the membrane is wrapped around the donor twin. Once you've identified where the donor is, then you can look for where the membrane works its way across the placenta. On the donor side, you have the leaflet of membrane coming down close onto the placenta because of the anhydramnios. So the donor side is slightly darker, and therefore you can see a line across the placenta. And the easiest way to then divide the placenta by laser is actually to follow the line of the membrane with a laser, like you can see on the right-hand side. And as you come across the placenta, you see the vessels that are running between the two sacs, and you can ablate those. And typically, you would want to separate the two circulations completely. So the easiest way to do a laser is to find the intertwin membrane and literally follow it across from one side of the placenta to the other, just drawing a continuous line with your laser. The problem with that approach is that often the vascular equator is not exactly in the same position. So the alternative process is to pick up the vessels that are crossing from one to the other and to then follow them back towards the recipient cord and work out where the anastomoses are on the placenta that demonstrate to you that one vessel's coming from the recipient, one's coming from the donor, and you can then identify the vascular equator rather than the membranous equator, and then you can do your laser across that level. So the problem with laser is it needs a lot of expensive equipment, and some of this equipment is also quite fragile. It's made primarily for other processes such as pediatric cystoscopy, and when you start to bend to try and get round the anterior placenta, suddenly you break the scope and the lenses in the scope. So it's a rather hazardous process in terms of expense, because I seem to get through a lot of scopes. Overall, in Australia, to buy the endoscopic equipment and to buy a laser for this procedure costs about $120,000 all in to set the service up. You then also have to train people in this process, so you have to decide where you want to do this. We do this in our fetal medicine ultrasound department rather than in theatre under local anaesthetic. But everybody that's involved needs to understand how the laser works, and you need to have rules and regulations and training around the use of laser in that situation. So it might be better to do this in operating theatre, where lasers are used for other disciplines as well, and where that experience already exists. So how do you decide where you're going to put the scope? Generally, the scope goes into the maternal recipient compartment, and that means that you've then got a lot of fluid to be able to see where the membrane is, where the vascular equator is. But before you start, I think it's really useful to identify the boundaries. If you're going to draw a line with a laser from one side of the placenta to the other, you need to know where the limits of the placenta are. So you need to map the placenta and know where the placenta lies within the uterus. That's a 3D process, because it often goes around a lateral wall or around the top or the bottom of the uterus. You need to know the orientation of the donor. Usually the membranous equator, particularly, is aligned with the orientation of the donor. So you have to decide whether you want to put a scope in and then run along the length, bringing your hand back, or whether you want to put a scope in and sweep across. So they're two different techniques. And then the other thing that you want to know in terms of identifying or mapping the vascular equator is, with ultrasound, you can first identify where the two cord insertions are on the placenta. And so once you put the scope in, you want to be able to move to the recipient look at the cord base, and then follow from that towards the donor. There is a discussion about the method that we should use. Traditionally, when we started doing laser, we were cutting the placenta in half, following the membrane. That was the way we started. Then we had this academic argument about following anastomoses, working out which anastomoses were important, and just ablating those anastomoses. That made the technique in some ways easier, because you were going to do an amnio drainage anyway with this procedure, and it meant you could put the scope in, and provided you could see one or two anastomoses, you could persuade everybody that you'd done something that was useful. But the problem, when you leave some anastomoses open, is that if one twin dies, then you can get death or brain damage of the co-twin, as we heard about in previous talk. So from my perspective, the best thing to do is what we call Solomonization of the placenta, which is based on the story of King Solomon, who the two potential mothers of the infant were arguing about who should have the child. He said, well, let's cut the child in half, and the real mother said, no, you can't do that. So it's the same concept here. We want to make sure that we cut the placenta in half. So what makes you sleepless at night is, did I get all of the anastomoses? And so being systematic about this process of working across the placenta is important. Usually I work across the whole of the placenta, and then I go back and I follow where I've been. Some of the bigger vessels, I will often then choose another site on the same vessel just to ablate again to make sure I've got it completely. And the reason that you really want to know you separated these twins is that there is a risk of ongoing pathology. So there's a risk of still having twin-twin transfusion. There's a risk of the twin-twin continuing but reversing, so the donor becomes the recipient, the recipient becomes the donor. And then there's also a risk of TAPS. And for us, about 2/3 of our cases of TAPS occur in situations where we've already done a laser. So then you've got the ongoing surveillance to check the growth, to see what the lichor looks like, to check for risk of preterm delivery by looking at cervical length, and to look at the MCA Doppler. And here, instead of looking at the pulsatility index like we were with the fetal growth restriction, we're now looking at the peak systolic velocity, looking for evidence of TAPS. And again, just remember the risks associated with filamentous cord insertion. If you have done a procedure on a twin pregnancy, that does subsequently increase your risk of preterm pre-labor rupture membranes. We have certainly had instances where preterm pre-labor rupture membranes has been associated with a filamentous cord insertion rupture, not necessarily vasa previa, not necessarily over the cervix, but in another site of the uterus, and we have had babies die as a result of that. In fact, I had one die 2 weeks ago from this. So this is a significant risk. Again, ongoing surveillance allows you to see changes such as here. You can see a bleed into the cerebral cortex. You can see this baby became anemic. It's also got hydrops. You know that if one twin dies, you have this ongoing risk of neurodevelopmental problem in the co-twin, so you need to think about delayed imaging to look specifically for that, such as loss of the cerebral mantle. You would not necessarily see that bottom right image if you were doing ultrasound-based screening, so MRI is particularly useful in this circumstance. And this is just a report of papers that tell you about neurodevelopmental outcomes for twin-twin transfusion. You can see that outcomes generally are better if you do laser than if you do amnio drainage, but there is a 1 in 25% chance that one or both babies could have some neurological problem post-laser, and I think it's really important that parents are aware of that. And in our circumstance, a significant portion of parents choose to have a termination of pregnancy rather than a procedure, and that's because of the risk of ongoing neurodevelopmental problems. And this is just a rather nice example of twins with taps post-delivery. I think that's all I've got. Yeah, thank you very much.